So for our next presentation, it's crisis services response for intellectual and developmental disabilities and other special populations. Dr. Pinals will be sharing information and presenting again during this session. As previously mentioned, she's the director of the program in psychiatry, law, and ethics, and the clinical professor of psychiatry at the University of Michigan Medical School and clinical adjunct professor at the University of Michigan Law School. We also have joining us today Wendy Bailey, who's the executive director of the Mississippi Department of Mental Health, a role that she assumed since January of 2021. She's been with the agency for 16 years, beginning her career at the Mississippi State Hospital. Recently received her bachelor and master's degrees and is a licensed mental health administrator. And then Mary Sowers, who joined the National Association of State Directors of Developmental Disabilities in 2014 and became the executive director there on July 1st of 2019. Before joining the association, she was with Mercer Government Human Services Consulting, where she provided consultation and technical assistance to state governments on a wide variety of Medicaid-related issues with a focus on integrated care, home and community-based services, and managed long-term services and supports. And prior to that, she held positions at the Federal Centers of Medicaid and Medicare Services, Disabled and Elderly Health Programs Group within the Center of Medicaid and CHIP Services. So at this point, I will turn the virtual microphone over to Wendy Bailey for this session. Thank you.
Thank you for having me. These have been excellent sessions so far, and we are learning so much here in Mississippi. We have several people who are participating, so I'm glad to be a part of today. You can go to the next slide. I was going to speak just a little bit about our experience in Mississippi related to crisis response, in particular for the IDD population. In our state, our Department of Mental Health is responsible for mental health services, alcohol and drug addiction services, and intellectual and developmental disability services. So that puts us in the position of needing to respond to crisis situations for all three populations. Next slide. We have several strategies at the moment that we're using, and we're building upon these as well. One is our mobile crisis response teams. We've also started crisis transition homes in our state. We are utilizing crisis beds at our state-operated programs, and we have something called the SPOT team that I'll talk about in just a moment. Next slide. So first, I wanted to briefly mention our mobile crisis response teams. We developed these in 2014. We have 13 community mental health regions in the state that are our main providers of community services. And we have a mobile crisis response team in each region, so they cover all 82 counties of our state. Our insert, we call them insert teams. Our insert teams work hand in hand with local law enforcement, with chancery judges and clerks, and our crisis stabilization units to try to ensure a seamless process and to avoid any institutionalization. Our goal is to try to respond in a manner where the individual is experiencing the crisis. Our teams are made up of a master's level mental health therapist, a community support specialist, and a peer support specialist. We have found that peer support specialist is absolutely key on these teams. Incorporating certified peer support specialists in a lot of our core services, but in particular on mobile crisis response, has been very, very beneficial for our state. You can see that from when we started in 2014 on these slides that the number of both calls and face-to-face interactions have grown. Over the last probably 2 years, we're having more responses for IDD crisis. So we are currently looking at some additional enhanced training for our mobile crisis response teams, because in the beginning, most of these calls were more related to mental health, and we are starting to see an uptick in that. we want to have a very robust mobile crisis response effort that does enable these teams to respond to all three populations. For example, if you go back to the assessment paper that we're here discussing during this hour, crisis services, it clearly states, must provide those healing environments with appropriately trained staff. And that is needed to meet the needs of patients with IDD as well. Next slide. We also have crisis beds for IDD. We started 2 different programs in our state, Matt's House and Success Homes. And these homes support up to 5 individuals who are in a crisis situation or at risk of being in a crisis situation. They're highly intense services. They're 24 hours a day, 7 days a week. It is intended to be a short-term crisis transition home for individuals who have IDD. And they also cannot be part of the IDD home and community-based waiver. So this fills sometimes a gap that states have of individuals who are not on the waiver and individuals who are not currently in a regional program as well or at a community provider. We have referrals that come from a lot of different locations in our state. Primarily, though, we have priority admission for our SPOT team referrals. In addition to the crisis beds at these 2 community-based homes, we've also set aside crisis beds at our state-operated IDD regional programs. In Mississippi, we do still have several of these that are in operation. There has been a very, very large decrease in the census and more individuals moving into the IDD community homes. And because of this, we have been able to isolate some crisis beds for that purpose as well. Next slide, please. So the SPOT team. Several years ago in Mississippi, we developed what we call a specialized planning options to transitions team. And the main goal of this team is to support people who have a high recidivism, people who continue to cycle in and out of the public mental health system. In the beginning, it was designed really to look at the mental health population for serious mental illness. However, it has expanded greatly over the last several years, and much of the time is devoted to IDD crisis situations. And we have a group of team members who meet on a bi-weekly basis, and they review the circumstances of people who are in need of person-centered support. This is a team that has team members from different state agencies. We have Child Protective Services, we have IDD, advocacy groups that are involved. We have local jails, crisis stabilization units, Division of Medicaid. We try to incorporate partnerships and people on these teams that at any point would touch the individual and can provide any of the supports and services needed for this individual to be successful in the community. So our team members come from a variety of backgrounds. Because of the SPOT efforts, just this past fiscal year, there were 171 people who were connected with services and supports. And again, I go back to these are individuals who are in crisis situations, who have sometimes no family members that are involved. They do not have a support system to lean on in many cases, and they have cycled in and out of the system. So it's really in our state meeting a need that we know that we have. Next slide, please. But we also know that there's challenges that we're still facing in our state, and that's why I think a lot of the presentations that we're hearing is so vital to see what other states are doing as well. We have a need for more crisis beds, particularly for this population. We have a need for more community providers who are willing to serve clients in a crisis situation, particularly those with intellectual and developmental disabilities. A lot of times we find that we may transition someone to the community, and as soon as they have a crisis situation, say they end up in the emergency room, the provider, they do not want to accept the individual back into their care. They want that individual to go back into a state-operated regional program, which is what we are trying to move away from. We also have a need for more waiver slots and looking at lack of benefits and benefit denials. And then, of course, staffing concerns. And we all have that, and we're experiencing that nationwide right now, and definitely experiencing that with all of our programs that serve crisis situations. Next slide. Some of the solutions We are focused in on bringing more training on IDD crisis response, particularly for those mobile crisis response teams. We have some additional funding through FMAP to try to enroll more people on the waiver. The crisis transition homes have also been very successful, but a lot of times you'll have kind of a backup in the system there. They're intended to not be any longer than 6 months, but we find that a lot of times they do. So looking at expanding our crisis bed capacity in general. Next slide. So while we have the challenges and we have some solutions as well, we do know that serving individuals who are in a crisis situation who have intellectual and developmental disabilities does bring on a new approach. And to try to incorporate that for all three populations, I think is going to be vital for us moving forward. In particular with 988, which is a lot of the discussion at this conference has been around 988. And while it's a behavioral health crisis line, we know that we're going to get a lot of calls related to crisis situations. So I think any enhancement as the nation and also in our states that we can do around crisis services for people who have intellectual and developmental disabilities and their family are going to be vital moving forward.
Okay, so so thank you very much, Wendy. So Mary Sowers, I think you're be presenting next. Thank you.
Thank you so much. I'm Mary Sowers from the National Association of State DD Directors, and Wendy, I'm thrilled that you went before me. It looks like there's some really wonderful things happening in Mississippi, and I'm sure that my remarks will resonate with you quite a bit. Our members, next slide, please. Our members, as our name implies, are the nation's agencies in the 50 states in the District of Columbia that provide supports and services to individuals, children and adults with intellectual and developmental disabilities and their families. And our members tend to oversee long-term services and supports, and in fact, oversee about a third of the nation's Medicaid long-term services and supports, both in the community and less and less every year, but also in institutional settings. Next slide, please. So I'm really thrilled to be among you today and very honored to be able to share with you some of the highest priority areas of our members. It won't surprise you, I don't think, to know that, of the 7.37 million people in the US who have an intellectual developmental disability, there's a high prevalence of co-occurring mental health issues, even on the low end of 30% estimated. We've got many people with IDD who also have mental health support needs. And I think one of the things that's been so wonderful in working with Brian and Deb and others in preparation for this conversation is just that growing recognition nationally that individuals with IDD are in fact people, and people have mental health issues. And so we just need to make sure that we've got supports and services that are adequate to support them regardless of other co-occurring issues that they might be wrestling with. And despite the high prevalence, our systems have done, while many strong efforts have not really developed a well-honed support system for folks with intellectual and developmental disabilities across the lifespan. Next slide, please. So as we sit here today, we're sort of left with some long-standing barriers that have really impeded those effective supports and building cross-agency collaboration. So as you'd imagine within state structures, there's the obvious challenges with service delivery structural silos. And those tend to be perpetuated by some of the funding requirements across systems and can be traced back to a lot of anachronisms even in the federal landscape on how services and supports have been offered. For folks with IDD, Medicaid is a really prominent method of service delivery, both for health and long-term services and supports. And a lot of the longstanding Medicaid policies we're continuing to wrestle with that were vestiges of the past. Our systems, like yours, are suffering from workforce shortages. We're recognizing that there's a huge clinical paucity of capacity to support individuals with IDD and mental health support needs. So that clinical capacity really needs to be built up, not necessarily to reinvent the wheel, but really to support clinicians to understand and effectively communicate with individuals who might communicate very atypically. But there's also an important component on in supporting individuals and families and direct support professionals. These are the folks who tend to breathe life into individuals' day-to-day activities and really help them have strong lives in the community. But they often aren't armed with strategies for sort of recognizing when to pull in clinical interventions or to support individuals in a manner that can stave off or prevent episodes from occurring. And we also often are finding that there's not a lot of clinical professionals who have that experience of working directly with an individual who might have a real circle of support around them, with families recognizing the importance of the community focus of the IDD service system. And as I mentioned a moment ago, we still have a sort of anachronisms and perceptions within funding sources that perpetuate some of these barriers. And these all are bureaucratic issues, right? Theoretically, we can come to solutions on them, but for sure they are stymieing as states are trying to devise strong approaches to support individuals with some of the most challenging support needs. Next slide, please. And so what this means on the ground is that there's less than optimal outcomes for individuals due to these things. And so for individuals with IDD, where our states, not a week goes by, actually probably not a day goes by where we're not communicating with one of our members on what are some effective strategies with supporting these folks. But there's an inadequate supply of the community supports as well as clinical. We tend to see an over-reliance on pharmacology, including psychotropic medications. There's often, I'm sure all of you on the phone have experienced individuals who become stuck between two systems, sort of the accountability with no one stepping, with both people feeling they're not responsible. Individuals can often get stuck literally, sometimes in acute hospital settings. And then there's the notion of being labeled difficult or challenging. And then these reputations tend to precede the individuals and wind up really influencing the types of supports and services that are available to them longer term. Next slide, please. So we've, identified and with NASMHPD and with the National Association of Dual Diagnosis have worked with a number of states on really trying to identify some strategies that would be key to improvement for a comprehensive service reform. And those are obviously, really working diligently within the state to overcome some of the organizational stovepipe issues and misaligned incentives across state agencies or partners, both in financing and payment, and even in just how services and supports are delivered. Obviously, cracking the nut with regard to increasing the clinical capacity and the specialized supports and training for direct support workforce is key as well. And that is sort of an oversimplification as we are really wrestling with direct support workforce crisis that is of monumental proportions as we speak. And so even DSPs for individuals who don't have pretty complex support needs are very difficult to recruit and retain at this moment in time. And then really looking at service design opportunities and innovations within state funding strategies, whether it's Medicaid programs or even state funded activities. Next slide, please. We've got some good news, and I think there's reason for optimism right now. I think at this time more than ever, we've got real opportunities to do better. I think you've heard as Mississippi has tackled some real cross-system collaboration strategies that enhance a whole person supports, really recognizing that individuals can present with many different challenges and devising an approach that is nimble enough to really support individuals with whatever might be the challenge at the time is really important. To make sure that there's both the availability of clinical capacity and system partner skills. And so really what we're talking about there is not only sort of making sure you've got clinicians available, but you've got system partners who can talk to one another in a manner that's productive and nimble and responsive, but also planful. And so we think about prevention and early intervention strategies, and we use those terms very broadly as the systems thinks about how to make sure that there might be supports and services in place before things get to a crisis situation. And so many of our members spend a lot of time talking about supporting families and really trying to provide those necessary supports and services early. And that can prevent the need for out-of-home placements, or it can also, in the event that an out-of-home placement might be necessary for a short period of time, can prepare the family in advance to a return to the community. And that goes for providers as well. You've really designed a crisis services continuum that supports individuals with IDD. We're often talking with our members on what are the strategies we can use in the moment when a crisis occurs. And we're really helping to devise, thinking about the before and the after as individuals are returning. As Wendy noted with their crisis settings, that sometimes people don't often transition back to the community as readily as they might often, and that plays itself out in every state in the union. And so it's really, what do we need to do to make sure that those transitions can really happen successfully after the fact? And there's a bunch of capacity building within our community-based system that's necessary for that. And then importantly, really keeping a focus on the individual and family-centered approaches, because even having some strong tools in your toolbox, it's still very necessary to understand what the individual is going through in the context of their families, and really taking that into account. And that's where, I think the communication across the systems becomes really important. And I think that we're seeing more states really try to devise those cross-system pieces. The other thing that is really important is that, while we've been talking a lot about the importance of mental health and IDD system collaboration, it can't stop there. We recognize that education and child services within the state, as well as Medicaid, have to be parties at the table too, and as you're devising really strong approaches to supports. Next slide, please. And then finally, we've got there, it's not a desert. There are some real hopeful activities that are happening, and I think there's some themes that have emerged from those states that have made some progress. I don't think any state would say they've cracked the nut entirely, but the states that have done well really have a reflective system analysis built in to try to identify strengths and build upon them. There's a commitment to collaboration and problem solving, both at the leadership levels within the state and across staff. The identification of those multi-level system interventions to enhance overall capacity, and a commitment to person and family-centered practices. And I should also say, we're increasingly seeing a very strong recognition of the importance of trauma-informed care as individuals with intellectual and developmental disabilities are seeking supports and services. Next slide. Both mental health and IDD, by the way. And then these are some states, it won't surprise you, with Dr. Pinals in the state. Michigan has some really wonderful practices, including, importantly, one thing we'll talk about is an ability to speak both languages. I think our systems all have their own jargon, and sometimes that winds up complicating our ability to work together. Sometimes we use the same words and mean totally different things. And so having someone that understands both systems can be extraordinarily beneficial in helping to bridge some of the chasms that exist. We've got great practices in Pennsylvania. They've got a capacity building institute. Missouri and Ohio also have some really promising practices. Next slide, please. And then just as you're all working to shape crisis services, again, making sure that there's the engagement of multiple systems. Again, not that everyone needs to be on site all the time, as Dr. Pinals mentioned earlier, but that there's that ability to reach out and get the necessary access to information that you require. And really ensuring that access is truly accessible, both in terms of disability, but also thinking about race and ethnicity and spoken language and alternative communication. So really thinking broadly about how individuals interact with systems and communicate. Ensuring that strong partnership doesn't end at the end of the crisis, but that there's continuity of supports post-crisis. And again, using that plain language, and really try to remove the system speak, both as you're interacting with one another, but it also becomes an important tool as you're interacting with individuals and families as well. And then finally, really building in those strategies to leverage needed expertise. No one system can have all of the skills necessary. And so it really requires building a lattice or a framework for partnership. And so we're really hopeful, and I think some wonderful promising practices are emerging on how that can be really effectively effectuated. So thank you so much. I think that's the next slide, but it's really an honor to be here, and I hope that the rest of your conference goes extraordinarily well, but we're really thrilled to have the opportunity to work with NASMHPD.
Thank you very much, Mary. Now I'm going to turn it over to Dr. Pinals.
Great. Well, thank you. And at the risk of everyone saying that they've heard enough from me, I'm going to go through, I was asked to kind of go over some of the work that we did actually quite a while ago, but it's very fresh now. And hearing Wendy and Mary, I mean, it's amazing to see what work has happened, and it's great to be collaborating. And I think what we heard about from Wendy is really just that, speaking the same language, and that is something I think we really need to continue to do. So you all already know who I am and all about me, so I'm not going to repeat that. This goes back to a paper that we were tasked with writing, and NASD's weighed in on, looking at the vital role of specialized approaches around people with intellectual and developmental disabilities in the mental health system. And my collaborators were Drs. Anneker, Mosh, and Hovermail, all representing different experiences. And really to try and further getting the word out about this issue and helping to educate the workforce, we worked hard to get that paper converted into two published papers that were recently released from psychiatric services. And so these were now peer reviewed, and they're even better than the work that we did before because of that peer review process that we had. So I think that this is something that is really exciting, that, you know, this conversation about working together between the state mental health authorities and the state developmental disabilities authorities are really, it's really coming to some reality. And I think crisis services is going to drive that even more. Actually, I see that I'm not inside mode. Okay, so I don't have to repeat what Mary said about prevalence rates, but it is really important to understand that at all levels of the system, both from the people on the ground providing the supports and services and care to the policymakers, there has to be this recognition that there's these overlapping populations, and that populations of persons with IDD and persons with mental illness will appear in our system in a variety of ways. And we are ill prepared, although again, there's pockets of hope, but overall we have been ill prepared to deal with this. This goes back to what you heard before about training. The Accreditation Council of Graduate Medical Education has literally no requirements for psychiatrists, general psychiatrists, to be trained in IDD. That's not true for child psychiatrists, so that you do learn a little bit about IDD in the developmental years. But when you think about the workforce, and this just speaks to psychiatry, it doesn't speak to social work, it doesn't speak to licensed mental health counselors or direct service workers, direct service professionals, or direct care workers, depending on which language you use. So really thinking about those training needs. A case, just to bring this home, was one that we encountered in one of the systems I was working with, a nonverbal young man in his 20s, whose father was his guardian and no longer able to care for him, something we see quite commonly where aging parents maybe are no longer able to manage how they managed at home when the child was smaller. He was served by the Public Developmental Disabilities Agency and had been in and out of adult foster care and group living placements related to aggression. But his residential providers had come to a point where they couldn't support his aggression because he was kicking walls, furniture, and staff. And so he was brought to the emergency department with no place to turn beyond that. As he increased his behavioral dysregulation, he was required to wait for a bed in the emergency department. There was no great place to put him, so to speak. There was no place to send him. And so ultimately it was decided that he would be admitted to an inpatient psychiatric unit, which really wasn't the right place for him either. He had been given multiple doses of antipsychotic medications, something we often see in the emergency department and in psychiatric settings, because again, there's not really an adept way of managing behavior other than trying to quell it. And on the unit, he again showed behavioral dysregulation that was concerning to the staff. He did some significant property damage, which then puts him in this, difficult to manage kind of category that, as you heard from the others, then relates, then when you're looking for proper placements, there's sort of a tag on this individual that they're just impossible to support in a positive way. And that just leads to denials of services and longer waits. And you guys, I think, all know this story in terms of how to, that these are the challenges. This was just another person with a similar thing, and it all sometimes relates to this behavioral dysregulation, but it could be completely related to a change in environment, a change in caretaker, something that's not related to other things. And also the lack of identifying the need, for example, that this person had autism spectrum disorder, minimal verbal skills, borderline IQ. And really it wasn't until an ABA, a person with who was knowledgeable in applied behavioral analysis, was able to help develop a treatment plan that she was able to be managed in a better way. Unfortunately, this woman was held in, again, an emergency department and restrained for almost 3 weeks total, and eventually placed in a state psychiatric hospital, and eventually, luckily, discharged really to her own apartment, home environment that had been adapted to her needs, and she was able to be stabilized in a really positive and meaningful way. But after a lot of back and forth with the community system and with a slow transition back, it was great to see her actually be able to return home. And this is one of our stories that I tell, and I actually bring trainees to, I have brought trainees to her home environment so that they can see what success can look like. Because sometimes when you work in an environment like a hospital where you only see these individuals in restraints or damaging property, you don't even have the ability to imagine a success of what it could look like. And so there are solutions and opportunities as we look at these partnerships in our interface, look at complex treatment frameworks and the ethical frameworks, and ensuring a properly trained workforce as we go forward. The systems issues, the weaknesses and the threats that we see: not enough staff, not enough training, not enough leadership that knows about these dual populations, improper placements, often over-reliance on medication, something that we really have to work hard to fight against. But then again, there might be a need for medications in systems that have traditionally not been biologically driven. And so trying to find that balance between appropriate and inappropriate medication is really important. The role of family participation and this whole fish tank analogy that everybody's kind of watching and trying to see from the outside what's happening without necessarily diving in to help problem solve. And this historical chasm, as I think we're hearing about, is really trying to get past that. Now, we heard from Mississippi where the agencies are combined. In Michigan, the agencies are combined as well. But it doesn't mean that the agencies need to be combined. I've worked in other states where the agencies are not combined, but at a leadership level, they are working together to really problem solve in terms of thinking about this. This idea of the dual diagnosis falling through the cracks, and really thinking about everybody's got a hand in this and we can all problem solve together. NADD, the National Association for the Dually Diagnosed, is an entity that really helps provide leadership in the expansion of knowledge, training, and policy and advocacy around mental health practices to help individuals who do have these dual diagnoses in their communities. They've developed the Diagnostic Manual that helps look at diagnoses from the DSM-5 and translates them for persons with intellectual disability. Lots of training materials available. There are these financing barriers, and yet there's also opportunities to think about this. The barriers being silos and fragmentation, exclusionary eligibility and coverage criteria, limited rates, and structural integration that's limited, protocols that aren't combined, versus the opportunities that we can look at for migrating from targeted populations in limited waivers to population health-based service delivery and payment reform strategies. States are looking at accountable care organizations, looking at behavioral health and long-term services and supports, provider partnerships to look at this service delivery so that we're not just getting the supports needed for the IDD issues, but services for the IDD issues with the behavioral health issues, the mental health issues, as well as medical issues that might be needed to support individuals on top, and re-examining the need to regulate the markets in specialty care. Some of these struggles go back, as you've heard, a long way through these different departments, Medicaid being a key driver in all of this as we go forward. So what we're seeing more and more are the Medicaid systems, the DD systems, and the mental health systems working together as we look at broader entitlements and trying to look at, instead of only looking at waiver services, but thinking about population populations as a whole. So the need now is really focused on, developing 988. How is 988 going to triage when you have a person with IDD or a person with co-occurring conditions? How is the crisis service going to really think about those individuals with IDD? What will care look like? And how will we train the workforce? And how will we integrate between behavioral health and physical health as key priorities? And as you heard from our Assistant Secretary yesterday, the need to integrate between behavioral health and physical health is a key, is a key SAMHSA priority. And I think that's really all the more important in this population of individuals with IDD as well. And so highlights for these recommendations include that people with intellectual and developmental disabilities, we can't forget, often have co-occurring mental health conditions. And getting treatment for their co-occurring conditions requires accessing bifurcated care to two siloed care systems that are coming together with some bright lights that we're seeing across the country, but really need to continue to push against those silos to more collaborative models. And even though there may be a lack of integrated care options, the need for a skilled workforce has long been recognized, and we have to think about these structural problems around professional and the training gaps for professional staff, as well as the direct care and direct support staff. Individuals with intellectual and developmental disabilities with co-occurring mental health conditions have to seek treatment by crossing over these systems where they're typically served, and the ED becomes the sort of, or crisis services now will become this ground of fodder for either dispute or resolution, depending on how we build it. And I think that's why it's exciting that this is part of this conference's conversation. Remember that there are distinct legal, regulatory, and policy issues that will need to be looked at as we go forward, as we examine those policies to further integrate care for these populations. And so the recommendations that we had identified through our special task force on this several years ago when these papers first emerged, we're really looking at, again, this issue of specialization versus generalization on inpatient units and now in other services, with consideration, if you're not going to be specialized and you want to have general services, how do you bake in that consultative opportunity to help get people the support so we don't have those cases that I described where people are in the midst of really difficult, challenging behaviors that the staff don't know how to manage or support to get to more positive outcomes. And so really creating organizational structures and infrastructure that includes data sharing, leadership coordination, workforce development and coordination, looking at opportunities for accurate assessments along a biopsychosocial perspective so that we are looking at care across an integrated framework, prioritizing self-directed care, person-centered care, and trauma-informed practices, enhance quality delivery of services and pharmacological supports when needed, but not to excess, devise a targeted health management framework with sufficient financial and performance incentives with coordination across DD, mental health, and Medicaid, look at systematic and systemic data collection and skill building. We also need to attend to forensic and criminal, legal, and juvenile justice involvement, because unfortunately these populations, oops, that's my timer, see, that was very loud. These populations are overrepresented in the criminal, legal, and juvenile justice systems. So we have to pay attention to that as a strategy. And then consider the workforce development. We've seen great successes in workforce development in other areas, and we are facing some dire times around that, but looking at what could be incentives to prioritize a skilled workforce. And with that, I think I will stop to make sure that this time we have opportune time for questions from our audience for all of our panelists.
Wonderful. Thank you very much, Dr. Pinals and Mary and Wendy. Again, a lot of information there. So I want to encourage, first of all, I want to point out to individuals that they haven't been following the chat that Neely Ezekiel has provided the links to the two papers that were referenced today. Encourage you all to, to copy those links and take a look at that information. So if you have any questions for our presenters, please feel free to either load them in the chat. You can send them either directly to me or to everyone, and or raise your hand and we'll call on you. And while individuals are thinking of questions, one of the things that I wanted to really ask, I think the three of you, because all of you touched on it, is the workforce. And so, looking at crisis response as we're preparing for 988, what types of skill sets and things or credentials should we be looking for to help to provide that integrated, whole person response?
I'd certainly defer to go ahead, Wendy.
Okay, I will say that's one thing that we're currently looking at, because the structure of our mobile crisis response teams, for example, and we know that 988 is going to coordinate so closely with that, is, as I mentioned earlier, more heavily defined on the mental health side. So making sure that looking at, do we need to expand the current makeup of those teams? Also, do we need to get some specialized training for our certified peer support specialists? Because our peer support specialists are on the mental health or the A&D area, and co-occurring with IDD and mental health is very common. So we know that we're going to get a heavier response, most likely with 988, then that's going to have to be addressed. So we're kind of looking at that right now, specifically with those mobile teams, and then also with our crisis stabilization units. I think so much of it goes back to training for your current staff, and then evaluation of any additional staff that may need to be added to address those situations.
Dr. Pinals and Mary, do you want to add to that?
Yeah, well, I think it's a great approach, and I'm not sure that there's sort of a silver bullet on one credential that will fill the shoes, but I think making sure that there are linkages built into the mobile crisis teams, folks that they can call out to, that can help them navigate some difficult challenges. As you'd imagine, individuals with intellectual and developmental disabilities aren't monolithic either, and so depending on the particular situation and the individual's maybe communication style and support needs, it might be important to just have someone who's familiar with the whole breadth of folks with IDD and can help the mobile crisis teams really navigate some of those issues. And if there, that might also be important, as Deb mentioned, the really using data to inform some of the policies too. If you're seeing that many of the interventions might be individuals who are autistic, that perhaps getting some folks with depths of knowledge with autism would be important. But importantly, I think just having that linkage with the IDD system and perhaps some folks who can be on call that can help navigate some of those waters would be extraordinarily helpful. And then, of course, training, some of the in supporting individuals with intellectual and developmental disabilities, sometimes it's just sort of taking extra time and making sure you're understanding, giving yourself a time to understand how people communicate and trying to put folks at ease. And so some of it might be some basic training that would be almost like a universal accessibility for anyone who might have some differences in communicating or nervousness in interacting with folks. So I think there might be some real strategies that could be universal precautions, if you will, as well as those expertise areas that you'd want to draw upon in particular situations.
Thank you. Dr. Pinals, was there anything that you wanted to comment on that?
Yeah, I mean, I think that's exactly right. I think we're going to need, I think given the workforce demands, having a specialist available in every crisis center I'm not sure that that's a realistic, maybe it'll work in certain regions. I just don't see it as always realistic. Of course, we do have telepractice that could make somebody available and on call, and some states are looking at, similar to how we have child psychiatry access, we have substance use disorder specialists available on call to consult. It may be that there could be some innovative ways, echo models, if you will, or other types of on-call models where you have consultation available. You'd have to build it from a crisis service perspective almost 24/7. But I think it's really a lot about building in some training for the generalists and then having that available network of potential consultation. And then I'm a big believer in a very clear policy for escalation of issues when there's something that's maybe over somebody's head or involves systemic barriers. Who do you call around the systemic barriers to tackle those? And so what's the policy for reaching out to the DD system if you have somebody that's there and their provider is no longer able to support them, as you saw in those case examples that I talked about?
Right, and in line with that, Dr. Pinals, you talked about pharmacological interventions as well. And certainly, you know, we've seen that where at times there's a heavy reliance on that where it may or may not be fully indicated. So I imagine that some of those strategies that you talked about could be helpful in addressing that as well.
Yeah, I think we're really going to need to take a biopsychosocial approach. You know, people will be coming in crisis. It could be because they're having some pain issue that they're not able to articulate, and it could be related to an acute medical issue. It could be related to, as a recent case I was just involved in, somebody who had suffered from abuse in a publicly funded group living environment and now was acting differently, and understandably so, but nobody could understand why there was a difference in behavior. So I think we're going to really need to look at the gamut and take that biopsychosocial approach, teach people to talk to collateral sources for people that are less verbal and the like. So there is work to be done in training staff on all this.
Great, thank you. And then we have a question in the chat box from Doug Thomas about how the mental health and IDD providers have done with collaborating with in terms of co-occurring individuals. So,
within Mississippi, I think, as Debra mentioned, of course, you don't have to have both your DD, your IDD, and your mental health together, but it is a benefit for our state because it is. So our providers also work very closely. We're pretty much consistent at the table together, so that's a benefit. Same way with the SPOT team that's been established in Mississippi. We have those mental health providers, those IDD providers, those other state agencies at that table each week. So when you have a situation come up that is co-occurring, you have everyone there together. So that's definitely a benefit with us. Same way with, you know, we had a situation just last week with a young man who has both IDD and a mental health disorder, and the community mental health center in our state a few years ago, we transitioned a lot of our community homes to operation by the community mental health center. So that really expanded their involvement and their work with the IDD population. So that has also kind of meshed into, you know, a stronger collaboration with the provider, since now those community mental health centers are more involved in both areas.
Great, thank you. Yeah, and Doug's follow-up comment was that in Utah, that their IDD system is a waiver system. So you're in or you're out of the system with a long waiting list. And in Utah, it just puts a lot of pressure on the mental health system to try to manage, you know, the mental health piece, as well as figure out what to do about the IDD issues while someone may be on the waiting list.
Doug, it's the same way in Mississippi with us. Our number on our waiver and our number on our planning list for our waiver is almost equal.
And that winds up playing out often across states, because the home and community-based services waivers do have, in most states, limited enrollment. And it's also another important piece to bring to the table, because oftentimes while individuals might be waiting for waiver services from the DD system, they might already be Medicaid eligible. And so there's often other services that can also be brought to bear to support them in the community. But it's, you know, if there's not that point of contact there, it sometimes is difficult. So it really big, you know, sort of, I think Deb used the stool analogy, but it really is important to make sure that you've got your sights on all the different supports that might be able to be brought to bear for any particular person, even if they might be waiting for long-term services and supports. And a lot more states are also, even for states with long waiting lists, are including There's something called reserve capacity in home and community-based services waivers, where the state can, for folks that have prioritization based on a whole host of different criteria, but a state could reserve for someone who might be in crisis or at imminent risk of out-of-home placement, for instance, or jail or hospitalization. And sometimes those long waits can be surpassed by that. So it's, Doug, certainly a point well taken for sure, and one that folks wrestle with.
Thank you. And then, and Brian, he has his hand raised.
Yeah, thank you. This actually builds on Doug's question. We know before COVID, systems frequently used terms like being dumped on by other administrations. And there was a lot of resistance, resentment at one administration, feeling that they were being put upon by another administration. Now we're coming, well, I was going to say we're coming out of COVID. I guess we hope at some point we're coming out of COVID, but right now we're short-staffed, we're burned out, people are on edge. It's real easy to touch the irritability level that people have. How do we, building on what Doug was talking about and building on the fact that we want to have a collaborative model, how do we work through that initial reaction is going to be one of more anger and irritability, and get beyond that?
I'll happily jump in, but Brian, if I have this solved, then we can all just pack up and go home. But I think you've hit on a really important point. But that said, I'm cautiously optimistic, because one of the reasons for that, I think that reaction is because both systems in our situation are often dealing with scarce resources. And so between some of the investments that are happening now on the crisis services and the investments, we've got life-changing investments happening on the home and community-based services side of things, both birds in hand right now as states are developing their spending plans for the enhanced FMAP, and potentially in the not too distant future if Congress acts on some of the things before them right now. And so I think that frees people up a little bit more to think about how to do some cross-system collaboration without feeling like they've sort of usurped those scarce resources in a manner that they felt should be shared or someone else's responsibility. So I'm hopeful that having a slightly better funded system of supports can take some of that pressure off. I don't know that it solves the irritability or the fatigue, which is real in our members' case. I mean, folks have been running at a breakneck pace now for 18 months, and it's just not sustainable. But I hope that some of the additional resources can sort of free folks up to be thinking creatively about that cross-system piece. So,
well, and I guess I would just jump in.
I think that the issue that I apologize, Deb. I just wanted to say that the home and community-based services piece, I think, is real exciting, because your organization and people, the administrations on the DD side, have had a lot more experience with home and community-based services than what we've had on the mental health side. And now there is an opportunity on the mental health side, the behavioral health side, to tap into home and community-based services. So that's a way that we could really take advantage on the mental health side of the collaboration. So it's timely. Thank you.
And the only thing I was going to jump in and say is absolutely, this is the time it's like you said, it's historic money that's never been there before to this magnitude in this way. But and I think the data that just came out from the CDC that you guys put in the NASMHPD newsletter that showed that the mental health impacts for people with disabilities from COVID-19 are higher than they are for the general population is just, I mean, follow the data. It is another reason why the mental health authorities, now is the time, and that's why I think you put this panel onto the NASMHPD commissioners meeting. Now is the time, between the crisis services and the data that we're seeing, to make sure that the mental health systems are reaching across the aisle and the DD systems are reaching across the aisle for that collaborative conversation. And again, the crisis conversation drives it, but so does other data.
Thank you. That's a great note to end on. Thank you very much. I really want to thank our panelists today, Wendy Bailey, Mary Sowers, and Dr. Pinals for just sharing your wealth of information today and on this panel. So thank you. And I'm going to turn it over to Brian.